We have a dedicated classroom. We have more beds. We doubled the amount of beds we had. We kept the same amount of primary exam tables, and then we had a small room for debriefing. We had a much larger control area, and we built our control area based on our program, and that was to provide the skills lab, and we had a capstone virtual hospital experience. So we wanted to definitely be able to see both our main lab and a smaller semi-private room that we had some high fidelity mannequins in. I hope you all had an opportunity to see our lab. We had a tour yesterday, and we just love showing our lab. So you should have been able to see that small initial high fidelity room. This is an example of how we wanted to maximize our resources. So we invested a lot of money in the audiovisual and in the capital expenditure of this space. So we figured, how could we maximize the expense of this audiovisual, not only to do the recording and the potential debriefing with the video, but how else could we utilize it? So we began to stream into the dedicated lab space. We started with that first to be able to see what our abilities were, how easy it was to incorporate that before we began to expand it into orientation. And it worked really well for us for the system that we had, for the amount of money that we had into that room, streaming with the InVivio audiovisual equipment that we had. In our present space, we have expanded to 6,000 square feet. We have 2 main labs now. We've also expanded our audiovisual capabilities. Here you'll see, once again, we kept the main lab with a control room because we still have that virtual hospital experience in our program. Our program has not changed. It's just the amount of space that we've had to dedicate it. We've also expanded our control areas because we wanted to bring in not only the ability to continue our skills lab in this section, but also do some perhaps simultaneous simulations that weren't necessarily related to a skills lab. We have multiple courses going at the same time, and we wanted to be able to have a control room for the main lab and another control room for an apartment setting and for an exam room. They're not necessarily tied to each other, and if we were going to dedicate that space, we wanted to be able to use it as much as possible within our entire program to get the most out of it. And we recognized we were going to go to community. We wanted to provide a much more broad community clinical opportunities for our students. And after seeing some mock studio apartments at other simulation centers, we definitely knew we wanted to build that in. So we put that in there. We had tours, and we showed that we had this space, and even though it wasn't necessarily built to exactly duplicate a mock studio, we made it work for what we had. We didn't put the plumbing in the bathroom, but we had the bathroom in there. So we maximized the space without necessarily with the expenditure. So in this whole process, we identified what our key priorities were. We focused our resources, and in building infrastructure, that's money. And the audiovisual, that's money as well. So we made sure we knew what we were going to do with our money, what's the high priority for us. And I'd like to talk about some other key priorities as well. But then after that, we'll begin to evaluate our practices, and we know we needed training. So all of that was part of how do we maximize our resources, going through this in a very methodical way, recognizing what we needed to do. Because if we didn't have a plan, we weren't really going to maximize our funds or what we needed. So another key priority for us is collaboration. And an element of that we wanted to focus on was on communication. So I'm going to bring this up as an example of the communication between faculty, staff, and students. And what we did, or what we've been doing, is we had a lot of face-to-face. We had a lot of face-to-face when we started. We were so small. A lot of face-to-face meetings. We called on the phone to each other. We had sign-up sheets for the lab, for the space, for the simulation, what was going on. And then we also utilized the internet as well. As we grew, the multiple admission starts that we had in our program, from a one-time year to a multiple times within the year, the increased student cohort size began to really deepen that fragmentation of the communication that we had. We began to evaluate our practice. So of all the things that we were doing, how could we do that better? How could we maximize our resources? And we began to pull in some personnel, which I consider a great resource, between information technology and academic technology. Academic technology is more like Blackboard, our web college providers, and the information technology, those people that help us with our computers and some of the other internet capabilities that we have. One example is the cloud-based data storage that the university implemented. So we went full on board with that. How could we utilize that in our lab? How did we put some of our virtual training exercises on the cloud rather than on the CDs that needed to be shared between multiple labs? Another example of that is how we wanted to communicate in the lab and as a school of nursing. So the School of Nursing started using this internet provider calendar, and we recognized we really needed that for the lab as well. So many things were going on in our lab. Multiple courses use our lab: the health assessment, the medical surgical, and then the capstone. And so we wanted to be able to say if there were competencies going, high-stake evals going, this lab, this, and there. We wanted to make sure that we were all communicating on the same page. So we began to use a multi-user, simultaneous calendar that anybody could access for the sim lab. And we found that that was really quite helpful. So now we just go on and we look to see. The other thing that we found very helpful for us, instead of just the sign-up sheets for Open Lab, we went to a sign-up on the internet. It's a Google Doc, but they access it through Blackboard. And the students could go in, sign up for Open Lab practice, and then the faculty who's manning the Open Lab station would be able to see how many students were there and what they needed to practice. And since we have multiple faculty rotating through Open Lab, we needed to make sure everybody had access to that. When we evaluated our practice, though, we already had this, we recognized that the turnaround time for students to be able to use the documentation wasn't as quick as we wanted it. It turned out that it took a little time. They had to register through Blackboard to get access to the Google Doc. I'm not sure if all of you have used that, but in that time frame may have been a little too long, and they missed their Open Lab because they recognized it took about 24 hours to get that through there. And normally 24 hours doesn't seem too long, but when our lab is at full capacity and the only Open Lab space you have is the next day, and they signed up afterwards, after clinical, after their classes, it turned out that we were missing an opportunity to be able to get them in there. So we went ahead and asked the administration, executive administrative assistants, to register all of our students at orientation. Just get it done, register them all, and they all have access. So now we've streamlined that even more. The collaboration that I'd like to focus on next is our material resources, not just our technology resources. So we feel that we can really accentuate learning by collaborating, and that means sharing what we have, sharing what we know, and being able to bring about that safe, quality, compassionate healthcare. And it can't be just within our borders. We have to kind of reach out. We reach out in an interprofessional way with Loudoun County. There's a LPN program with the public schools, and they have a very difficult time finding OB sites. Yeah, it is. So we have collaborated with them to provide an OB birthing experience. As soon as we got that sim mom, we went ahead and said yes to people who had been asking us. Got trained on that and went ahead and brought them in and were able to provide that experience for them and we consider that a very critical part of our collaboration for interprofessional. We plan on expanding that, but that's just one example. This slide here is just a community outreach. We're bringing our mannequins out to a local high school career fair, trying to get people interested, the students interested in nursing. what we can provide. That's not necessarily our audience for population for our program. We're an accelerated BSN program, but we still feel that it's really important to be able to say, look, there's more to nursing than perhaps what you might recognize. We get them talking about it, and so we have brought one of our mannequins there. The collegial collaboration, I don't really have a slide for, but it leads me into the next part of what I'm going to say. The collegial is within the faculty. And how do I maximize the resource I have in this lab when we all have to share it? We have to share it from the skills lab, we have to share it for the SIM experiences that we're doing. And how do we do that? So one example is in health assessment, they like to use the mannequins because they can pre-program the mannequin to have certain vital signs. And they can stay that way. And so without having a standardized patient for health assessment, you can have that mannequin there all day long if you need to, and multiple days when we have our labs on multiple days. But if I have my med-surg lab going at the same time, we have to share that same mannequin that's already pre-programmed for certain things. So we've had discussions among the faculty about what patient do you want this to be and how could I use that in med-surg as well. So we don't duplicate, but we actually just build on that. So we share our resources so that they don't have to actually get another mannequin, put it into the same lab space that we share. And that leads me to no space. There we go. Is that it? Ah, yes. Okay, so another sharing of what we wanted to do. This is a picture of a Pyxis machine. It's very similar to an AccuDose machine if you haven't seen a Pyxis. There are computerized medication dispensing in most acute care facilities if they've gone to those. And our students see a lot of those. And I wanted to be able to bring that in as a current technology for the students to increase fidelity and the experiential learning. However, we're not dedicating any resources to that at this time, so how can we actually maximize what we have to replicate in some way in our SIM? Because we found that having to restock the medication carts in our virtual hospital was quite time consuming. And so we went ahead and decided what we were going to do is we were going to create our own Pyxis station, a semi-automated Pyxis station. So what we did was repurposed an old medication cart. We started out with in that very first lab when we just had some very limited resources. We took the shelves because they had multiple shelves in them, labeled them from A to Z, and put them single unit dose medications in them. It is low cost, we repurpose, and now we're going to be able to incorporate that in a virtual hospital. The director and I had said, this is such a great idea. We only have to stock it one time. Not only will we stock it for virtual hospital, we're going to stock it for their very first med-surg lab. So now the students, instead of having to go to a patient drawer and pull it out, they'll just come to the Pyxis, even from the very beginning. And so we've utilized it now between two different courses, the very last semester and then the very first semester. We have another one as well, and we're going to be using that in the med-surg 2 lab. And it's just the same. So we have some older medication carts. We're now making them into our Pyxises until we can dedicate the funds that we need for those Pyxises or AccuDoses that are out on the market. The other example is our audiovisual. This is the original audiovisual. We're using it just in the lab classroom there. The streaming capabilities, we were so proud of ourselves. However, we knew we were going to upgrade. And when we did upgrade, we went to a higher resolution audiovisual company that was able to provide what we needed, and we had a potential growth. So even though we were spending more money, we were going to leverage that audiovisual in multiple ways beyond the SIM as a school of nursing. So here we have streaming now for the fundamentals blast simulation during orientation in our main classroom to a much larger group. We stream within our med-surg labs. We stream in our OB courses. We stream in our health assessment, and we record throughout all of our labs. And in addition to the increased audiovisual, we just didn't think about our sim lab when we bought our audiovisual equipment. We thought about it all. Where else could we do it? How else could we leverage that? And we incorporated a company and the technique that to be able to communicate, because communication and collaboration was one of our key resources. We're a multi-campus facility, so we incorporated that technology into our teleconferencing room within our sim lab. So now we are able to do video conferencing with that equipment between the campuses in Foggy Bottom, Mount Vernon, and here. And not only does the School of Nursing utilize that, but there are other programs within our university that utilize it as well. We want this for the potential to develop even more our interprofessional education. We're associated with George Washington University. They have a school of medicine. They have an allied health school. And we're really hoping to be able, even though we're separated by distance, to be able to increase our collaboration efforts because of the video conferencing that we have. So we've talked about space, material, people, and time. So considering how do you maximize your time, because time is very important to me. I have limited amount of time and a lot to do with it, and there's that concept that you have to do more and more with less and less until eventually you can do everything with nothing. But I haven't yet seen that fully materialized. However, that concept of doing more and more with less and less, I feel relates to time, because we really do have a very supportive leadership as far as funds, capital, space. But they can't give us more time. So we actually have to figure out how we're going to utilize that time. And one of the ways that we do it is very simple. It's so simple, and I don't understand why I didn't catch on to it sooner, was how to utilize a schematic to increase efficiency. I was going to have you do a little exercise here, but there's so many of you. I'm so glad all of you came. So we're going to just have you do it in your head. The schematic, this is a really poor schematic if you're an engineer, okay? This is also a really poor schematic floor plan if you are a designer. However, I'm a lab faculty, and I needed to be able to say where I was going to put my resources that I share between courses, and with the different programs that we have, where are those mannequins, what are we using them for on a weekly basis, actually on a daily basis, and do I need to switch them between beds, what can we use them for every lesson plan that we have. And sometimes that did involve changing the mannequins around or knowing the fidelity of the mannequins we had. Because after a while, if we have a mannequin for every bed, you start to forget which fidelity mannequin you had in which bed. To quickly be able to kind of get over that, I had to recognize I had a mid-fidelity here, a low fidelity there. I had a mannequin that had two accesses for central lines. If I was going to cannulate both of those mannequins, I needed to be able to say, could I have 4 students at this bed, 2 students at that bed, and only 1 student at that bed. So I needed to be able to do that. This is a simple one, I think, for week 1 on female catheterization. What was the gender of the mannequins in that bed? So I didn't have to keep thinking about it. And how was that going to relate between med-surg, where I could put them, and what else could I do? So when I was drawing my schematic, simple rules: you don't have to fill up the paper. Don't be afraid to leave blank spaces. Don't get overwhelmed with a lot of detail like doors, because I've certainly left that out. I've also incorporated some concept spaces like classroom and simulation spaces. So I would just begin to put down where I wanted them. And once I made that schematic, that went on the computer, and every week I just filled that in based on what I needed to do. So it was highly efficient for me, so that I didn't have to worry about what was it again that I did. I just went ahead, put that down, had it, and I was able to move on. The other important thing on that is if I have people helping me, they know where to go. They know which mannequin needs to be cathed which one is going to be utilizing a different procedure. I also used some extra space because I didn't want to have to go flipping between pages, because that's time consuming as well, and I wanted to know what supplies I really needed to have out. If anyone was going to help me set up, I needed to have that kind of listed out. I needed to have this is what I wanted. I had some supplies out. It helps me keep track of the supplies I'm using week to week. So if we're doing a lot of task-based simulation, skills, remember this is a skills lab in addition to a simulation, I need to keep track of that. We have also a rotation schedule. I won't go into that. It can get very complicated, as Gretchen knows, but it keeps me on track. And if I know what we're doing station to station, and 20 students in a lab, and they all have to go through about 2 to 3 stations, it keeps me on track and everybody else, so that they can get the learning accomplished in that time frame. Another way to maximize time, and this is student time, this is learning time, is how we incorporate what we do for documentation. This is a simplistic documentation form utilized for electronic medical records. We definitely wanted to bring that into our simulation. So we thought, how could we do that? So we used some donated laptops. We bought an inexpensive EHR record. Went through the EHR record, picked out what we wanted to incorporate for virtual hospital, because that's where we started it was virtual hospital. And then after we piloted it in virtual, we expanded it to MedSurg 1 and MedSurg 2. So now we use the same resource for 3 different courses, and the students who are beginning in MedSurg 1 in the past, now we've proceeded past that, are now familiar with this document all the way through their program. So if the less time they have in the clinical area to chart, the more time they have in our sim lab to chart. And they don't have to spend a lot of time trying to figure out how to document that particular thing that we want them to. We concentrated on one area, our focus, and that was medication, and we went ahead and did that. So just in summary for my part, we identified some key priorities for us: infrastructure, communication, collaboration. We focused our resources, whatever that was, whatever that priority is, we focused our resources to it. We evaluated our practices. Once we actually have focused our resources toward it, we just evaluated, was it working? And we continually do that. What have we spent our money or our time or our resources wisely in this area? Is it achieving our goal? And then we have to acknowledge that once we dedicate resources and time to a priority, that we're going to need to acknowledge the need for training for that. And Gretchen's going to bring that forward in a little bit more detail, a little bit more personal level as far as that's concerned. And this is just one example. So here we have an instructor who is in that first lab using the walkie-talkie and the headphone. Since we didn't have an advanced microphone system and visual camera system, she's looking right through and she's interacting with the students using a microphone. We were very low scale at that point. So, and then going into our new lab with our touch panels and the increased audiovisual, we definitely needed to have more training for that.
Well, good afternoon, everybody. As the moderator, I guess, said, my name is Gretchen Wiersma, and I am a pediatric nurse, and my main job is clinical. So I'm talking to you today about simulation. Anyway, how many of you guys are pretty new to simulation? Anybody here? Okay, so I'm pretty new to simulation, but I've had the pleasure to work for the last few years with Mrs. Seaton, and she wanted me to come talk about some of the things I've done within the pediatrics within our simulation lab. So I have but one objective to cover in the next 15 minutes, and it's the impact on the management of resources component in a simulation lab, and specifically I'm going to talk in reference to pediatrics, because that's what I do, pediatrics. So we're looking at, when I first started here talking about the stakeholders. When I started here at this program, I actually started out as an adjunct, having moved from Roanoke, where I was at Jefferson College of Health Science, and I saw one of my former bosses, I guess, here today. Anyway, I started as an adjunct, but then was hired as faculty. So the first year I actually was not involved in any of the simulation that students did, so I was never part of the enterprise building. When I first arrived here at the university, they had 20 students, and we had clinical a couple of days, and they spent limited time in the lab in reference to pediatrics. The faculty, they had, I think, 3 full-time faculty. Mrs. Seaton wasn't here yet either. I think Mrs. Davis, whom you guys have met, was one of the 3. Now, we now have, I think, 12 to 15 faculty. It's kind of in limbo because we're in the hiring process right now, just FYI. And then you say, why am I talking? Well, because I have a pretty extensive background in the clinical setting in various roles in teaching. I've taught at the LPN level, the ADN level, the BSN level, and I actually was a clinical staff nurse on the pediatric unit down the street at Inova Loudoun Hospital until a couple of years ago when I just became too busy to continue working at that job and this job. So, and I've been involved with the lab in many ways, shapes, and forms, primarily pediatrics. And students, initially we had 20, then the next year we had 38 in our second cohort, then the next year we had 70. Then we started 2 semesters admits, 70 in the fall, 36 in the spring, and now we're starting with 60 again. So now we have 3 different groups of students all embarking on our lab at the same time. Well, not really at the same time because we have a very detailed schedule, as you saw. And our students are in an accelerated program, so they have but 4 semesters to get through, and they have pediatrics the 3rd semester of the program. So, talked about there was 1 lab with 1 control room, and it's in the current building that we're in, which is Innovation Hall. The pediatric material was pretty limited because is not the main focus. So we had just your basic static infant mannequins, low fidelity, and I'm told I guess some of them are mid fidelity. I don't know exactly the difference, but they're not high fidelity, I can tell you that. And we had limited pediatric supplies because there was really nobody focused on pediatrics that was within the lab. We did have a crib though. So the impacts of the growth, what's occurred since? Well, the university, we have more students, so the students are paying tuition, so we do have more funding, and some of that funding has been put forth, as you saw, into expanding the lab. Having more students means that we can't coddle them as individually because there's just so many of them. So we have to start thinking a little bit differently about how we're teaching our students. The faculties, we have to have more training and we have to have more faculty. And then the material, and I'll talk a little bit more detail about the different materials and how I adapted within the pediatric program for the growth. So we're looking at the key things we're going to look at are flow, time, materials, technology, and personnel. Starting with materials and technology. Well, one of the things, working in the clinical setting, I take students to Children's National Medical Center in Washington, D.C. for their pediatric clinical rotation. I worked at Inova system, which is a huge system in Northern Virginia. I know what's in the clinical setting for pediatric patients. So common sense tells me that we should be doing what they're doing in the clinical setting. So one of the key things that we try to accomplish during pediatrics is medication administration. And for those of you, anybody pediatrics? Couple. And do you guys use these pumps? Syringe pumps? Syringe pumps. Okay. So syringe pumps, they used to use something called the Buretrol, and those are kind of gone. Does anybody still use them? Okay. Anyway, so the syringe pump. So trying to get a syringe pump was key. So working over at Inova Loudoun Hospital, I said, hey, can we borrow your syringe pump so we can teach the students how to use it when they give medications? And having worked there, they said, sure, just come, sign it out, blah, blah, blah. And then I let our lab director know that this is a supply that we need to really maximize our students' time while they're in the lab. And they come, for pediatrics, they come one day for what we call the BLAST training, which is the basic learning assessment training, skills training, there you go, skills training. So we wanted to maximize that. And then they also, depending on where they go for their preceptorship, will depend if they get a pediatric patient or not, which I'll talk about later. So they have limited time in the lab affiliated with pediatrics. So maximizing it is key. We want to make sure that we have proper use of the mannequins and the equipment. The mannequins, while they are low fidelity, making sure they work, making sure the crying baby is able to cry, and I'm on that button, you better believe it, with the crying baby and the coughing and the wheezing, making all those pediatric sounds. And the pumps, once we were able to acquire the pump and didn't need to borrow it anymore, just making sure that we know how to use it and we get the necessary materials. So I'm, letting Mrs. Davis and Mrs. Seaton know what's the tubing we need, what are the syringes we need with these machines, and kind of working with them and training the other personnel, faculty involved on how to use it. So we had more training with the technology, and I was involved when we opened the new lab, and we had virtual hospital, and it was overwhelming. The first day we had headphones, and we had touch screen, and I had 2 stations, and I had a child over here and a baby over there, and sometimes it was working and you had to press this and do that. Even though I went through training, I was still not ready. Plus, some things were not working exactly how they should have because it was the first time. But we had more training, and we finally fine-tuned it to say we'd only want it to do A, B, and C, and they've been able to adjust. Audio-visual recording, she talked about streamlining. One of the big things with medication delivery also is being able to, we used ampicillin, which is a very common medication, so we have the students reconstitute it and then dilute it for delivery. So going through the whole process of interacting with a patient and then also showing the students using the streamlining how to go through the steps and then put that onto Blackboard so then they can keep referring back to that through the entire semester to just once again maximize the time. So we did get the funding. One of the things we've done within the training is also for the students, because we have bigger groups of students coming through, we really have to be even better at promoting them for active learning, get them involved, have them do some of the teaching, not just me standing in front of the mannequin explaining how to do it, but have them start to demonstrate and work with each other as groups to kind of give feedback to one another to really get them to be self-directed in their learning as well. We bring in all of our adjuncts, make them a part of that day. So early on, making sure we know what day we're going to be having this training so that they have understanding and buy into it too. Really makes it for an even more meaningful experience. Then the other thing to think of is when I'm having the pediatric training, one of the things we try to have a station that represents all the age groups, key age groups, and some of the key things. And also identifying some of the experts. Who do you encounter when you're a nurse in the pediatric setting? Who are some of the other experts? One of the other experts is child life. How many of you are familiar with child life? Those of you with pediatrics. So child life, once again, reached out over to INOVA, contacted the child life. She came over. Child life, for those of you who don't know, they come and they help kids to deal with hospitalization. They do stress relief, distraction, patient education that's at their developmental level. They can provide like Wii games or just depending on what they're able to do and what resources that the facility has. So they're a very strong part of pediatrics. And then respiratory, there's kids, one of the largest reasons why children are hospitalized is due to respiratory illness. So contacted my sister-in-law, happens to be a pediatric respiratory therapist at the Children's Hospital of Philadelphia. So I brought her in. And I said, bring a bag of stuff. Come prepared. So they're asking her a million questions. Some of them was more about me, the Mrs. Wiersma, not anything about pediatrics or respiratory. But still, so recognizing who do you know, what connections do you have? Because who better for them to ask about certain things than the expert? Because that's the reality. When you're in the clinical setting, there are pediatric respiratory therapists are all around you. So what happened then is the students, when they went into clinical, they're saying, I think we need to consult child life for this child, really recognizing that they're out there and actually taking the initiative to get them involved. We've had some success. This is a picture of our blast, where you see this is the nursing instructor on the front right, working with our infant patient, so they're all kind of gathered around, and you can see in her hand, she actually has the module that makes the baby do different things, because sometimes there was a lot of interference or it would not work correctly, so she got a little bit closer. The students really enjoyed it. It was really low stress, a lot of fun, so we got a lot of good feedback from that. Pediatric simulation was the other big thing we did. We did it when we had limited sites, like many of you do. We're fortunate now we've been able to kind of get more sites. But we had to do pediatric simulation for some of our students because we didn't have enough clinical sites for them. We also do simulation, which is embedded within the virtual hospital. So we developed patients with the help of our simulation experts, like Mrs. Seaton and Mrs. Davis. So we have specific patients, age groups with common problems. So you see this baby again with the instructor. The other thing we did with the Brett McFarlane with the asthma is I got the asthma pathway and incorporated that into the simulation using the evidence-based practice. What is the best practice out there? Because asthma is a huge problem. So just teaching them, this is what you're going to see in the clinical setting, to recognize what the pathways are and how they work and what your role is going to be as a nurse. And then we had the adolescent dealing with the non-compliance, typical things that you see in adolescence as related to diabetes, and just the student here trying to talk to the patient about why. And we had like the student was texting, the adolescent was texting and just kind of incorporating some of those common behaviors. Then with virtual hospital, we had a dedicated pediatric room. You can see we have the stuffed animal, and there's some other little things making it a little more pediatric friendly, and you see the student is down at the eye level of the patient. So students that were going to be going to their capstone for their preceptorship to pediatrics, we made sure that they were assigned one of the pediatric patients. Then those students that were assigned to pediatric patients, the scenarios were run by pediatric faculty, recognizing what are the common responses, behaviors that you're going to encounter with whatever age group of patient that we're working with. So in summary, Mrs. Seaton started out kind of giving us the big picture of our program and maximizing the resources as they relate to the different aspects of the flow. And I'll tell you that schematic that she put up there. So Mrs. Seaton gets in, the students, if they come in late, that's trouble. But anyway, so she reads, okay, you, A, B, C, D, E, get in groups, blah, 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 and then she walks out and they're like, Mrs. Wiersma, what did she just say and how do you read this? And I'm like, so luckily a few people in the group got it, and I'm like, I'm not sure, let me go ask. Because she won't, lay into me. But anyway, but it does work and it makes things go smoothly and it really does maximize the time. And then just like myself, who was pretty oblivious to simulation, just recognizing the value that it has, being able to manipulate the environment so that the students are learning those things. I can't tell you how important it is to bring the clinical faculty as much as you can and really get them involved with the simulation, because it just, there's just so much value in it. We are very fortunate with the technology that we've been able to get. We have great support from leadership in the university to get that technological training, and the equipment, still learning on how to use that. And then just the flow, having a system for things has been very key. And here's our references. Are there any questions? Not a one?